My name is Joe Sweigart. I'm a career hospitalist at the University of Kentucky, and I do all direct care hospital medicine, so take care of patients full-time for a living. Heart failure is essentially poor forward flow that comes from the heart, and it's important for a number of reasons, mostly because it affects so many patients in the country and it affects them so dramatically in terms of quality of life and quantity of life. It's important for my work as a hospitalist because it is increasingly clear that as hospitalists, we ought to be starting patients on the best medications possible as soon as possible, even during their index hospitalization. When I'm explaining this to patients, I have a little picture that I draw where I draw a heart and divide it into left and right side and a little stick figure. So the left side of the heart pumps the blood out to the person, they use up the oxygen, back to the right side, pumps it out to the lungs to get new oxygen, back to the left side. And it just keeps running like that. And so if the left side of the heart in particular isn't functioning well, that pressure can back up first into the lungs, and that causes the respiratory symptoms that we're familiar with, dyspnea on exertion, orthopnea, PND, and then ultimately into the systemic side of the circulation, which is when we often meet people with lower extremity edema kind of climbing up their body. Heart failure comes in two different big categories, systolic and diastolic. So systolic heart failure is a problem with the pumping function, moving the blood forward. Diastolic heart failure is that the heart doesn't accept the blood because the heart itself has become too rigid. Systolic heart failure, the pumping problem, is sometimes called heart failure with reduced ejection fraction, or HFrEF. Diastolic heart failure, the kind of rigid heart that doesn't accept the blood appropriately, is sometimes called heart failure with preserved ejection fraction, or HFpEF. So in general, systolic heart failure, or HFrEF, has at least 4 medications that need to be started all the time, and I tend to think of that as related mostly to coronary disease that affects how the pump function of the muscle works. For diastolic heart failure, or HFpEF, we have only a couple of medicines that have really been clearly shown to help, but the evidence is moving quickly. And this one I tend to think of as more related to long-standing hypertension that makes the actual muscle of the heart too big and too rigid. So in addition to systolic or diastolic heart failure, there's also other subcategories. So strictly speaking, heart failure with preserved ejection fraction has to have an ejection fraction above 50%. Whereas systolic heart failure, or heart failure with reduced ejection fraction, HFrEF, has to be an ejection fraction below 40%. The obvious problem there is that people who fall into the 40 to 50% category, or sometimes echocardiograms as read as like an EF of 45 to 55%, so it's hard to know what to do with those. There's also this category of reduced heart failure that improves. This is heart failure with improved EF, or heart failure with minimally reduced EF, so it gets pretty complicated pretty quick. The number that I carry around with me is 50%. An EF above 50% is normal, and anything under 50%, even though it may not strictly meet the research criteria for HFrEF, is probably best treated as if it were systolic heart failure with the initiation of goal-directed medical therapy. Heart failure is one of the edematous disorders, and so one of the sort of most common and most frequent symptoms or signs that we see is lower extremity edema. Edema can also happen, of course, with liver failure or with renal failure. And what's a little bit unique to cardiac failure is that we often see respiratory symptoms. Because heart failure often leads to pulmonary edema and increased pressure and increased volume in the heart, people often have reduced exercise tolerance slowly over time, shortness of breath, particularly with exertion, and then orthopnea, which is where they really feel like they're short of breath when they lay flat. I practice in Kentucky where they always say they're smothering if they lay too flat. And then there's also what's called paroxysmal nocturnal dyspnea, where people wake up from a dead sleep and they just can't get enough air in. And those respiratory symptoms, in addition to lower extremity edema, pretty strongly suggest some variation or some form of heart failure. I think the two most important shifts in the evidence for heart failure right now are both related to inpatient starts. So first, the guidelines are very clear on managing heart failure, particularly systolic heart failure, or HFrEF. Patients should be started on all 4 goal-directed medical therapies during their index hospitalization. So that includes beta blocker, ARB or ARNI, mineralocorticoid receptor antagonist or MRA, and an SGLT2 inhibitor. And as hospitalists, we really ought to be pushing hard to get patients started on all 4 of those prior to discharge if possible. The other thing that's new in the most recent revision of the guidelines is that IV iron, which I have long been a proponent of, is also really helpful in improving quality of life for patients with heart failure. And there's evidence saying that even an iron infusion during the index hospitalization before they leave our care can really help these patients long term. My advice for people caring for patients with heart failure is to be really aggressive. I think that this is the trend in the evidence over the recent years. we as hospitalists in particular have a really important role of aggressively decongesting or diuresing patients, and then being really aggressive to get them started on these medications. The evidence doesn't tell us exactly how to do this, but I think the biggest impact seems to come from the ARNI, that's an aldosterone receptor and neprilysin inhibitor. The SGLT2 inhibitors also have really great evidence and really big impact in studies. Then the mineralocorticoid receptor antagonist, specifically spironolactone, then one of the evidence-based beta blockers. Although the optimal order isn't unclear, it is clear that we should be starting patients, pushing hard to get patients on these medicines during the index stay. All of these agents have a mortality benefit within 30 days and a survival benefit that extends beyond 5 years. So they help a lot immediately and in the longer term. And I think that that's why the advice is to be aggressive. I think one of the really common pitfalls in heart failure is over-reliance on testing and undervaluing of our sort of clinical exam and overall gestalt. So the echocardiogram is probably the biggest example. We get a lot of unnecessary echocardiograms. That's true everywhere that I've ever worked. The evidence actually recommends that it's probably best to assess the left ventricular function a few months after initiation of goal-directed medical therapy, but we often get echoes on people frequently, several times a year, sometimes every few months if they're coming in and out of the hospital. So over-reliance on echo and wasteful spending related to getting too many echoes, I think is a really common pitfall that all of us, including me, fall into often. The other thing is the BNP, the beta natriuretic peptide. While it can be really good for undifferentiated patients, is not that helpful in patients who already have established heart failure, and I think sometimes can misguide us into diuresing too hard or diuresing not hard enough based on that value and how it trends over time. It has good prognostic value, specifically at the time of discharge, but doesn't have a lot of day-to-day value and can sometimes be really misguiding when we're admitting patients who already have known or established heart failure. It's hard to predict what the future of heart failure looks like, but I think it's going to be different mostly for speed, particularly when patients get admitted. I think that the length of stay is going to continue to decrease for heart failure, as is already happening. And specifically, that's going to be with a lot of emphasis on getting a few medications started initially, getting them decongested as quickly as possible, and then quickly transitioning them to the outpatient space with really close follow-up. And I think that this is going to require a couple of things. One is those transitions have to be more smooth from the inpatient space to the outpatient space. The other is I think we all need to get more comfortable with goal-directed medical therapy. Maybe that includes even starting some of it in the ER with our ER colleagues, and maybe that includes starting it on the day of discharge or prescribing it for them to start at home even after they leave our care. Probably this lends itself to some sort of combination tablets or combination medication starts. And my hope is that the evidence will clarify exactly what order and what doses we should be starting these medications in the future. But I really feel like the difference, particularly in hospital medicine, is going to be speed. Patients used to get admitted for weeks for heart failure. Now it's a few days, and I think it's going to get even shorter.